Hi, I'm Dr. Mike Kaplan, the medical director of Uroshock USA. Erectile dysfunction, sadly, is very common, even in guys in their 20s. In fact, recent studies show that 30% of guys in their 20s suffer from some degree of erectile dysfunction. So a lot of guys in their 20s say to themselves, I'm 20 years old. I can't possibly have erectile dysfunction. And in fact, most of the time, they do just fine. But they may find themselves with increasing degrees of difficulty. Now, they may say, well, that's okay, or maybe it's not okay. And I have to make a baseball analogy. A lot of players, they hit 250, maybe they hit 280. They're acceptable Major League Baseball players with an okay batting average. But maybe they don't want to be a 280 hitter. Maybe they want to be a 300 hitter, or maybe they want to bat 400 like Ted Williams. And now there are things that guys can do to get their batting average up and to make things better. So traditionally, guys who had a little bit of a problem, maybe needed a boost from time to time, would try a drug like Viagra. And the initial results are almost always spectacular. There's a very good reason that Pfizer has earned tens of billions of dollars from Viagra. And 20 years ago, when it was introduced in the United States, it was an absolute game changer. It opened up free-flowing discussion about erectile dysfunction and helped invite patients to bring up the subject with their doctors, which previously was all too much taboo. Viagra inhibits phosphodiesterase type 5, which is the erection killer. Most of the PDE5 inhibitors are in the penis, but unfortunately, they are also found elsewhere in the body. With drugs, there are always some side effects, and Viagra, Cialis, Levitra, and Stendra are no different. There are some side effects. There are some unpleasant side effects. So what we know is that when patients take drugs like Viagra or Cialis, the overwhelming majority of them will have a wonderful response initially. But 6 months down the road, 30% of the patients don't get their prescriptions refilled. And 18 months down the road, 50% of the patients stop taking the pills. And of course, as we mentioned, there are side effects, and all the PDE5 inhibitors, Viagra, Cialis, Levitra, Stendra, they all share a certain common characteristic, in that they can cause headache or flushing, nasal congestion, nasopharyngitis, or an upset stomach. There is a phenomenon in medicine which is called tachyphylaxis. And what that means is that certain drugs, patients will become habituated to it, and the drug will stop losing its efficacy. That is not the problem with Viagra. The problem is that whatever caused a patient to require the use of the medication, that process is ongoing. So if there's an occlusion of the vasculature because of atherosclerosis, that process will continue. And so Viagra or Cialis, they're being asked to do more and more. And because of that, they tend to lose their efficacy over time and the Viagra stops working. Now, traditionally, when that has happened, what we have done in urology is we have offered alternatives, which include a vacuum erection device, which is a plastic cylinder that patients put their penis inside the cylinder, a vacuum is created, and then they're asked to place a constriction ring around the base of the penis. Very awkward. They've been offered intraurethral pellets. Alprostadil is placed into the urethra, and you can only imagine how pleasant that is. We've asked patients to inject medication with little needles into their penis. Also, not a great joy. And finally, we've offered patients the option of undergoing surgery. So in the past, when patients fail to respond to medication, they were offered some rather draconian options. And you might say, well, what about testosterone? Doesn't testosterone have a role in all of this? And the answer is, it does have a role, but testosterone is not a necessary prerequisite to getting an erection. I had patients that had zero testosterone, and they were still able to engage in sexual intercourse. The problem is that there was a loss of libido, a loss of desire. So testosterone is important. It's important for vitality, for vigor, for libido, for musculature. It has a role in concentration, but its role in erections is supportive. Testosterone replacement alone as monotherapy, unfortunately, will not restore erections. There is an abundance of data that suggests that low intensity shockwave therapy will have a vital role in the treatment of patients who suffer from erectile dysfunction on both ends of the spectrum. For patients that just want to have a little boost, and maybe they're just starting to notice a mild decline in erectile dysfunction, low-intensity shockwave therapy can have a regenerative effect and can help open up the blood vessels. And for patients who are on the more severe side of the spectrum, patients who are no longer responding to PDE5 inhibitors may find that with low-intensity shockwave therapy, the pills are now more effective, or they may not even require pills in order to engage in sexual intercourse. The beauty of low-intensity shockwave therapy is that there seems to be very few side effects. It's very well tolerated by most patients. Most patients can undergo a treatment and then simply go on and live their normal lifestyle. In other words, there's no period of convalescence. There's no period of recovery. They can undergo a treatment, and now they can even undergo a treatment in the convenience of their own home and get on with the business of the day.